Hello, and welcome to the third webinar in the International Knowledge Exchange Network for Mental Health webinar series, Perspectives in Child and Youth Mental Health Care and Youth in Care. My name is Nicholas Waters, and I'm the Director of the Knowledge Exchange Centre at the Mental Health Commission of Canada, as well as the co-chair of the International Knowledge Exchange Network for Mental Health, or IKEN.MH. Just before we get started, I wanted to go through a few housekeeping items. I invite you to send questions throughout the presentation or comments using the chat feature, which can be found on the right-hand side of your screen. If you can't see the chat box, look for the icon on the upper right-hand corner of your screen that says chat. It looks like a little bubble, so click on that and then chat window should appear for you on the right-hand side of your PowerPoint slides. We encourage you when you're sending your questions to the presenters, if you could please use the drop-down menu and select all panelists. That way, the questions will go to myself as well as the presenter, and I will ask the questions on your behalf. To chat with other attendees, please select all attendees. The webinar is also being recorded and will be posted on the Mental Health Commission of Canada's website in the Webinar Archive section approximately 2 weeks following today's webinar. We will also be posting the slides from today's webinar in both English and French. Also, due to the large number of participants today, we've muted all of your phone lines just to eliminate any background noise. Before we begin the presentation, I'd like to briefly introduce the IKEN.MH to you. The IKEN.MH was jointly envisioned in 2012 by the Mental Health Commission of Canada and the International Initiative for Mental Health Leadership, with the idea of increasing the capacity for effective knowledge exchange in mental health by connecting people, ideas, and resources on a global level. The IKEN.MH is comprised of 7 leaders in mental health featuring representation from Canada, New Zealand, Sweden, England, and the United Kingdom. The goal of the group is to reduce the time from innovation to implementation and improve population mental health by building capacity and infrastructure, creating knowledge exchange research and tool development, utilizing technologies to enhance connectivity, and lastly, to increase the uptake of evidence-informed knowledge, which leads us to the IKEN.MH webinar series. The IKEN.MH is hosting a series of webinars featuring a variety of best and promising practices related to mental health and knowledge exchange. Many of the topics presented are themes that will be represented at the 2017 IMHL Leadership Exchange in Australia next year. The webinars will feature presenters from different countries and topics to share international perspectives to colleagues around the globe on what works best. We encourage you to provide us with your feedback after the webinar and update us on topics you might like to hear about. As well, I ask you to complete our post-evaluation after the webinar so that we can properly evaluate our series and adjust as necessary. Our first presenter is Michael Williams from New Zealand. Michael is a steering committee member of IKEN.MH Network. In addition, he is the Director of Operations for Youth Horizon, a New Zealand-based non-for-profit which specializes in interventions for children and young people diagnosed with conduct disorders. He is a clinical psychologist with experience implementing evidence-based treatment interventions into organizations and has spent the last 8 years working as part of the leadership team to transform the agency through international best evidence programs in partnership with an indigenous cultural focus. Michael has a keen interest in the planned child welfare system changes in New Zealand because of the profound difference to the life outcomes of the child welfare and youth justice population in New Zealand. The second presenter, Despina Papadopoulos, is a knowledge broker at the Mental Health Commission of Canada. She has her Master's in Education and leads Knowledge Exchange Centre's work on child and youth mental health and was the project manager for the Consensus Conference on the Mental Health of Emerging Adults. She also provides knowledge exchange support on the workplace, first responders, and the Recovery Initiative, where she led the development of the Mental Health Commission of Canada's inventory on recovery-oriented resources. So let's begin. I'll hand the webinar over to Michael now.
Thank you, Nicholas, and hello, everybody. Today I'm going to be talking to you about what a recent expert review panel found is wrong with our current care and protection system and what it recommends that the government do about it. I'm actually very hopeful and optimistic about the recommendations that they've put forward, and that's partly because the signals we're hearing from government is that they are listening to those recommendations, taking them very seriously, and that they intend to act on them, and acting quickly and with new funding. So it's an exciting time to be working in our sector. There's great anticipation amongst those who are working with vulnerable children and adolescents that the coming changes to our system should bring tangible, measurable, sustainable improvements to their life outcomes. I'm going to be speaking to you today obviously from my NGO manager's perspective. So it's based on information that's publicly available. So I'm not inside the tent, so to speak. I'm working with these children the teams I'm involved with are, but I'm not in the government agency or one of the decision makers around these changes. Kerry, would you want to change it to the next slide, please? So just a bit of background for those of you who don't know too much about New Zealand. We have 4.7 million people, and about 1 million of those are children and young people under the age of 18. About 15% of the population is our indigenous Māori people, and I'm going to be talking to you a bit more about the Māori in my presentation because, like other colonised people in other parts of the world, they do suffer a disproportionate burden of social and health problems. And one of the key aims of the changes in our child welfare service is to improve the lives of Māori children. Let's move to the next slide. Thanks, Kelly. Our state agency for care and protection of children and young people is called Child, Youth and Family. It is responsible for receiving and responding to notifications of abuse and neglect of children. Its social workers gather evidence to assess the validity of claims of abuse, and they make decisions on whether children need to be removed from home or whether the families can be preserved with the addition of support, often from other agencies such as ours. There are approximately 5,000 children and young people at any one time that are placed in care, and Child, Youth and Family receives approximately 60,000 notifications each year from members of the public or professionals who have concerns about children that they observe or believe to be being abused or being mistreated in some way. The frontline agency staff are mainly social workers, and they are very committed, very hard-working staff, and it's definitely true to say there's some pockets of excellent practice that happen within Child, Youth and Family. However, it's also the case that there have been multiple reviews of this agency over the last 2 decades, and they have consistently found that this agency is failing to meet the needs of our vulnerable children. There have been many attempts to shift the agency's approach and to restructure it to improve these outcomes. But considered collectively, these have failed dismally, unfortunately. Just an example, we did a study of a cohort of 21-year-olds who had a care placement at some stage in their life. So these were 21-year-olds who had been born in 1990 or 1991. And what was found is that by the age of 21, almost 90% were on a benefit. Almost 20% had had a custodial sentence, they'd been to prison, and almost 40% had a community sentence. And that's pretty typical of the types of outcomes that we're seeing for children who come through the service. The new minister set up Antolly, and she came into her role fairly recently. She has come out very strongly, saying that she does not accept that the outcomes for the child and family are appropriate. She has called them atrocious even. And she has said that she's unwilling to accept any more tinkering around the edges. There have been a number of attempted restructures of child and family. None of those have led to wholesale changes or made a meaningful impact. So she's been preparing our country for the last couple of years for what she's described as a bold overhaul of the system. And not just this agency, but actually the linkages, the broader system across health, education, police, the NGO sector, the Māori providers, and all of those components of the system need to work more effectively for the benefit of the vulnerable children and young people. So how she approached that is she set up an expert panel, has international experts, local experts on it, who listened to the voices of children, voices of families, the experience of social workers in the system, and talked to agencies such as ours, and the best local and international evidence, and spoke to international experts. Their remit was to completely redesign the system. If they had a blank slate, how would it look? The panel has now reported back, and excitingly for us, the government has agreed to implement at least some of its recommendations. We don't know how many yet, but clearly the intent there from government to make a big investment in doing some of, hopefully even all of these changes. The answer to the ministry, of the Child, Youth and Family, is a new ministry will be formed. It's going to stand up, it's going to become effective from April 2017. The new name is the Ministry for Vulnerable Children, Oranga Tamariki. Oranga Tamariki is Māori, translated that means the health of children, the well-being of children. The new ministry will have considerable funding, although just how much is not clear, and the remit to make major changes to how the services are delivered for our most vulnerable group. The actual number of vulnerable children that are going to fit within the focus of this ministry is not quite clear yet, but it's a bit of an indicator. About 1 in 5 children in New Zealand will have some form of contact with child, youth and family before the age of 17, or before the age of 18, sorry. Next slide, thank you. So previous reviews noted that there was a lack of clarity and purpose for the agency. There was insufficient response to the growing number of notifications. There was over a 200% increase in notifications of the agency between 2002 and 2014. And that's a trend that was mirrored across many countries. The primary driver of that was notifications for emotional abuse and neglect. Actually, the levels of physical violence against children and sexual abuse have stayed fairly static. And the impact on that on the agency was that social workers had unmanageable caseloads. The agency had become reactive, it had become an incident-driven service, with inadequate workforce planning. The expert advisory panel also found that there was insufficient cultural competence, staff, and the way that interventions were approached, and a lack of investment in prevention and evidence-based approaches. Can we go to the next slide, thanks. Now, this is consistent, the findings are consistent actually across other studies and other protection systems. In Australia and United Kingdom, for example, they've identified very similar issues, where there are increased costs, increased demands, barriers to cross-agency response, high staff turnover, high caseloads, and a focus on these urgent issues rather than an investment in prevention. And of course, too, this disproportionate negative statistics for indigenous populations and minority children. So, what are we going to do about it? That's the big question, and here's the answer. If we could turn to the next slide, please, Kelly. So, the expert advisory panel has made 81 recommendations. Big report. I'll put the link at the back of the slide so that you can click on that if you wish. And it's going to start with the new ministry. There's work going on right now to form that new ministry. A new chief executive has been appointed, new leadership has been appointed. There is a new operating model that's going to be developed. And the key themes of that will be that this is a very child-centered approach, looking at what's best through the lens of the child. And it's going to be an investment approach. The government has been saying for some time now that it is willing to spend more money at the front end, in the prevention space, if it can see that it's going to reduce the long-term costs to the state. And as more and more evidence gathers internationally that best practice interventions do just that, the cost-benefit works out as an ultimate benefit, they're becoming more and more willing to take that approach. That's a very positive thing. Their recommendation is that these, you'll see these on the slides here, these points become the driving principles for the new agency, that it ensures that children have the earliest opportunity for a loving and stable family. These are children who are in desperate situations, many of them, with appalling situations of abuse, neglect, deprivation, poverty, mental health issues, criminal issues in their family and their parents, drug and alcohol issues in the family. So they really do need loving, stable families. So there's a focus there on prevention. Helping children and young people to take responsibility for their actions and to live crime-free lives. So that speaks to the importance of having evidence-based interventions that are known to work internationally to reduce offending behaviours in young people. And addressing the full range of needs for each child. What happens now is our services are so fragmented that health, doesn't talk to education, doesn't talk to police, doesn't talk to child and family, and the children are often falling through the gaps. Service barriers prevent the most needy children in our population from actually getting the services they need. That's going to change. Also, we're keen to prevent the further victimisation of children in care or when they return from care. Helping children heal and recover and supporting children to be flourishing adults are two key drivers too. Next slide, thanks, Gil. There are 5 core improvement areas that are being focused on. One of those is prevention, another is transition support. That is the transition from when young people are in care to exiting care into adulthood. And that, for New Zealand, that's at the age of 17 currently. And what happens currently is that, 17, even if you've been in care for all of your life, government stops funding, child and family withdraws by and large, with some exceptions, and more or less left on their own. And this is a time in life where there are tremendous vulnerabilities, as you know. So that support is going to be increased. Child and family is going to extend, the Ministry of Vulnerable Children is going to extend the age range. There will be intensive intervention that's evidence-based. There will be care support services where there's greater focus on the support, care, and recruitment and retention of caregivers, and also the evidence base of our caregiver programs, and new programs coming into the youth justice space. Next slide, thanks. The response to the report has been, I would say, overwhelmingly positive in New Zealand. There have been some criticisms which will come through later, but by and large, certainly our agency, the people in our sector that are considered the experts in this space are saying this is looking really, really positive. The government follows through on the recommendations, and the leadership is good, and if there's sustained investment in this approach, it should make a big difference. Our current Children's Commissioner, Judge Andrew Beecroft, has said that he's reassured that this expert international committee has so accurately identified what is needed to improve the lives of our children. They've made a number of very appropriate and considered recommendations. Now that's fairly typical of what others are saying. Next slide, thanks. So just a bit of a scan through some of the changes that are coming up. So this is, there's a huge number of changes actually. So this is not by any means a complete list. It is a 4 to 5 year program the government's embarking on. It is going to take a huge effort. It's a massive overhaul. And it involves changes to legislation, changes to the operating model, structural changes, changes to the NGO sector, changes to the way funding is delivered. It really is a major wholesale change. So just in the first year alone, there will be legislation changes to increase the age of care to 18. That will bring us in line with many other countries in the world, including many of those of you who are listening today. In New Zealand, it's currently 17. We'll establish an independent youth advocacy service that will be funded through the philanthropic sector as well as the government, and its task will be to put the pressure on governments and social service providers to ensure that going forward that we are delivering the best services for young people. There will be a partnership with Māori services to build the foundations for strategic partnerships to develop interventions in those communities with those people, to research and measure them, and to put the resource in there to make sure that they can be effective and can learn from the changes over time. That's a big piece of work that's going to be starting this year, at the start of next year. And there'll be a focus also on caregiver recruitment, retention and support, and some care standards, some expectations around the qualities that caregivers need to have, and the level of support they must have. Across the board, there'll be a focus on trauma-informed intervention, particularly in the care space and in the transition space. And there's going to be a number of early enhancements in year 1 for care services in particular, and one of those will be an attempt to reduce the number of young people and children and young people who are in secure residential services. Government's keen to reduce the number of beds in the secure space and to find community-based interventions that will be more effective. So they've gone overseas to look at some of the best practice interventions, and Treatment Foster Care Oregon is one of the ones that they may consider. Next slide, thanks. In the second year, they'll be bringing in a direct purchasing model, which means that money will follow the child. At the moment, because of the siloed barriers between various parts of government systems and various agencies, often these children are missing out. The new agency will have the ability to directly purchase from NGOs or from other agencies such as Education and Health in order to meet whatever their needs are. So that could be purchasing counselling sessions, specialist appointments in paediatrics, education services, for example. There'll be a redesigned care continuum to ensure that all levels within the care need, from those who can be placed with kin and with a minimum level of support, through to those that need intensive support for their caregivers. There'll be a new transition support service. The agency I work for actually has a transition support service now, but there's only 2 of them and they're both in Auckland. There'll be some kind of expansion of that, I imagine, across the country. Just how that will look, I'm not quite sure. And there'll be an increased suite of responsive interventions to Māori. In the third year, there'll be a new operating model in our residential homes. There'll be new intensive interventions for families. Some of those could be things, the Good Advisory Panel has made recommendations around introducing functional family therapy, multi-systemic therapy, treatment foster care Oregon, teaching family model, triple P, cognitive behaviour therapy, parent-child interaction therapy. There's just a long list. There's family partnership, for example, to pilot initially, and then as those pilots demonstrate success, scale those up at a national level. And there'll be new intensive interventions for youth justice. So I'm picking that'll be things such as functional family therapy and MHCC. Next slide, thanks, Jeff. There'll be a better data platform built in Year 4, and legislation changes too, which will enable better data sharing and information sharing across various agencies. And in Year 4 is when they launch the new prevention service, which will target those aged 0 to 5, which I imagine will be things such as triple P, nurse-family partnership. And there'll be some interventions too that rolled into the education services. The new agency will have a vulnerable children's board that sits above the chief executive of the agency, that has the chief executives of other agencies, from health, education, police, so that there's an integration of all the key elements of government in the focus on these vulnerable children. Next slide, thank you. There have been a few criticisms of this new system. One of the most prominent ones in New Zealand right now is criticism about the name. The Ministry for Vulnerable Children is, and I agree with this criticism, is a stigmatising name. We don't call our Ministry of Health the Ministry of Sickness. We don't call our Ministry of Education the Ministry of People who can't read and write. But we are calling our children the vulnerable children. And I think it's going to make it difficult, actually, for members of that workforce to turn up at homes with the vulnerable children name tag, and for families not to feel stigmatised by that. However, it is what it is, and I'm confident we can still make that work. One of the ways that's been recommended by our Children's Commissioner is that we call it by its Māori name, which is a hopeful name. It's a strength-based name, Oranga Tamariki, the well-being of children. There's also a concern that it's a focus on a minority and may create gaps for other children. So as more resources get funneled into the very vulnerable group, there'll be less available for universal services. So that'll be interesting to see how that plays out. And perhaps the biggest concern of all is that poverty is not directly addressed by this change. And there's some very strong arguments that many of the same children, if not all, or close to all, who sit in this vulnerable group are also the group that sit in the approximately 300,000 children who are considered, at least by some measures, to be living in poverty. Nonetheless, I think it's a bit of both. Certainly you need the changes to the system, and we need to focus on poverty. Next slide, thank you. So, if you boil it down, it's an 18-leaflet solution. What the panel is saying is that we want our vulnerable children to have the best chance of leading a full and happy life, they have the best chance if they live with families that give them lifelong, stable and loving relationships, and if they belong to communities which cherish them. That's the goal. So simple yet very challenging to achieve. My hope is that the challenges that are coming up will bring us much closer to achieving that. An aspirational change, the transformation of our service, and I, for one, getting excited about it. You'll see down below there's also a reference there for you for those who are interested in seeing the full report. So thank you, and I'll hand it back to you, Nicholas.
Thank you, Michael. Just a reminder to participants that if you do have questions for the presenters, to send them via the chat function, and we will, after Despina's presentation, be addressing the questions that you've sent so far. And so if you have questions, please put them in the box feature, and we will now pass it over to Despina.
Great. So thank you, Nicholas, and thank you very much, Michael. My name is Despina Papadopoulos, and I will be leading our discussion today. So in our discussion today, I hope to discuss our consensus building process in the context of child youth mental health in Canada, to speak to some of the work at the Mental Health Commission that draws from authentic youth and family engagement, to discuss the work of developing a consensus statement on the mental health of emerging adults in Canada, and to discuss the knowledge exchange approach and implementation strategies, and that will be used to disseminate increased uptake of the consensus statement by engaging a broad group of stakeholders across Canada and internationally like yourselves. So for those of you who are not familiar with the Mental Health Commission of Canada, the Mental Health Commission was set up 9 years ago by the government as a nonprofit organization, and we were asked to develop Canada's first mental health strategy. Our mandate was to catalyze and change attitudes, to improve mental health, and to transform the care system. And we do that by working very closely to develop partnerships and to collaborate with experts in the field, and also with people with lived experience and their families, as well as their service providers. And our work really touches on a variety of areas and initiatives. And instead of really delving into that now, I encourage you to visit our website at www.mentalhealthcommissionofcanada.ca. One of the major areas is, of course, child and youth mental health. I'm going to speak to some of that work today. And some of the past initiatives that we've been involved in include our school-based mental health initiative and evaluating programs that are aimed to reduce stigma among youth. And now we're promoting the uptake of good practices through the Headstrong initiative, which you can also learn more about on our website. Our most recent work has focused on contributing to the conversation on improving the mental health of emerging adults, and that's what I'll focus mostly on in today's discussion. Next slide. Oh, before that. Oh, sorry, next slide. So why did the Mental Health Commission consider the mental health of emerging adults as a priority? So you're going to hear me use the term emerging adulthood quite often, and it's a term that's defined as a very distinct period of lifespan development occurring between adolescence and adulthood. And the term is often used in the mental health field to describe youth between the ages of 16 to 25. In some jurisdictions, they'll look at it or use as young as 14 and up to 29 or even 30. And this is a very distinct and significant period of time where there's a lot of intellectual, social, physiological, and neurological growth and development. And different jurisdictions often use other terms such as transition-aged youth, transitional-aged youth, young adults, or even simply youth. And it's a time when young people are ushered out of the child and youth mental health and addiction services and into adult services and programs. And too often these transitions are far from seamless and cause major disruptions to the well-being of young people or emerging adults. What we know in Canada is that an estimated 70% of mental health problems have an onset occurring childhood or adolescence, and 1 in 5 or 18% of young people aged 15 to 24 will report experiencing mental illness or substance use problems. And this is why this is an area of significant policy concern in Canada, because current policies, programs, and research that support the needs of emerging adults or EAs are often scarce. So the Mental Health Strategy for Canada outlines a number of recommendations for action on child and youth mental health. And in particular, it recommends the removal of barriers that can prevent successful transitions from child and youth to adult mental health and addiction services. So what we know is that to remove those barriers, authentic youth and family engagement is very important. And at the Mental Health Commission, we've tried to practice inclusive and authentic family and youth engagement in our work, and I'm going to provide a few examples for you. So during our first 5 years, we took a lot of direction in this area from the Child and Youth Advisory Committee under our committee structure that we had then. And under the current structure, we still have this voice on the Consolidated Advisory Committee. We also have a very engaged youth council, and they translated the mental health strategy into a youth-friendly version, and it has become routine now to engage them on most of our projects, or all of our projects. Excuse me. In producing Taking the Next Step Forward, which I'll speak to in the next slide, the team consulted with experts from around the world, including families, caregivers, and youth. And emerging adults were integral in the development of the consensus statement and our consensus conference. And we specifically called them our Emerging Adults Innovators Panel, which I'll speak to a little bit in the next couple of slides. So a few years ago, the Mental Health Commission issued an RFP, which was awarded to a research team from the Children's Hospital of Eastern Ontario. And this report, which is called Taking the Next Step Forward, Building a Responsive Mental Health and Addiction System for Emerging Adults, details the current state of policies and practices of youth who are transitioning from child and youth to adult mental health and addiction services. And in this report, it identifies the emerging good practices in Canada and some internationally ones, and offers a series of recommendations. This document is available on our website, and the link is available on that slide if you're interested to review it. What we learned from this report is that there are pockets of excellence in Canada, but they don't necessarily meet the developmental needs of emerging adults. So a lot of work really needs to be done. And this report became the foundation for our consensus conference, where we wanted to really engage the full spectrum of stakeholders implicated in the mental health of emerging adults about what concretely needed to change and how we could do that. But before we move forward, I just wanted you just to take a second to think of a few of these discussion questions and think about your own practices and the work that you're engaged with. So what are some good practices in your jurisdictions that engage and respond to the needs of emerging adults? So is there something that's working well in your community or in your country? And how can we learn from your existing networks and benefit from your knowledge? So as I mentioned in the previous slide, we hosted for the first time a consensus conference on the mental health of emerging adults. And we based our approach on the success of Alberta's Institute of Health Economics had with earlier consensus statements on improving care for depression and severe mental illness. The goal of this conference for us was to develop a consensus statement with concrete recommendations that would aim to improve the mental health of emerging adults and to address the challenges that they currently face in the service systems. This conference took place over 2.5 days last November. We had over 200 people attend, and there were quite a few policymakers, youth, caregivers, and quite a few service providers from across the health, mental health, education, justice, child welfare, and social service sectors. We actually spent quite a bit of time developing targets and engaging individuals from various sectors because we knew how important it was to engage not just individuals from the mental health sector, but also from the education, justice, child welfare, and social services. We also did provide some subsidies for the youth and caregivers who attended the conference. We modified this approach a bit, and the reason we did that is we wanted to make it more participatory, but we also really wanted to work with advisory groups leading up to the conference. So we worked with a panel of emerging adults, which we called the EA Innovators, and a group of leading experts and policymakers in mental health, and they helped us to co-design the format, the themes, and outcomes of the conference. We also wanted to ensure that there was enough dialogue from all the delegates at the conference and that their input was really heard and considered as we were writing the recommendations. So we purposely created more opportunities for dialogue between the delegates, the speakers, and the jury members, which I'll speak to you now. So the conference was anchored by presentations from 12 speakers who presented evidence and addressed specific questions developed by the 2 advisory groups, and each presentation was structured under one of 4 integrated or interrelated policy themes. And the EA panel, made up of about 7 to 8 young people, also presented after each of those themes and spoke to their own experiences. We had a 16-member jury panel who listened to all the speakers, the EAs, and the conference delegates, and they deliberated to develop recommendations that they brought forth to all of the conference delegates. And similar to the speakers, the members of the jury and the EA innovators were individuals that were made up of representatives from across Canada. They represented a wide spectrum of knowledge, expertise, and sectors, and again included mental health, justice, education, emerging adults and caregivers with lived experience, diverse populations, as well as First Nations, Inuit, Métis experts in the mental health field. We really wanted to ensure, once again, that their voice of the delegates and the EAs were heard. So on the final morning of the conference, the jury presented its draft consensus statement to the delegates, who then discussed it in groups and provided oral and written feedback. And we took all of that feedback, collated it, and worked very closely with our jury and the innovators in the months following the conference to finalize the consensus statement. So within this final consensus statement, we have a few components that we've included. Those components include a section on emerging adulthood, equity, diversity, racism, and vulnerable populations, mental health and substance use and abuse, and the distinct mental wellness needs of First Nations, Inuit, and Métis youth. These were actually components that were really advocated for by the youth, and we really wanted to ensure that we included those pieces within the statement. During the jury deliberations, it was also decided to develop a series of principles to underpin and cut across the more action-oriented recommendations, and the jury felt that these principles would help to ground them. And within these principles, they supported as being an underlining guiding concept for the recommendations. And some of these principles, which are further elaborated in the consensus document, include equitable and timely access, hope, collaboration, emerging adults as full co-creators, client-driven and holistic approaches, flexible mental health care, locally, culturally, and relevant services, responsive to the needs of vulnerable populations, family-oriented, and consistently evaluates its own performance. The document also includes 13 recommendations, and we've grouped them into 3 different categories. The first focuses on foundational to change, the second addresses service gaps, and the third backbone support for generating momentum and to sustain change. Within the foundational to change section, a lot of the recommendations focus on recognizing emerging adulthood as a developmental stage of life, making sure that we collaborate and joint partnership with EAs as experts. We have a placeholder right now that says TBT for our First Nations, Inuit, Métis stakeholders, and I'll speak to that in our next slide. We also talk a little bit about applying principles of health equity, anti-oppression, and anti-racism to tailor approaches. We also talk about intersectionality, individual identity, social and cultural context, and authentic family engagement. The next section, addressing the service gaps, focuses more on how we can create a seamless recovery-oriented continuum of care, removing barriers to collaboration and integration of services, and investing in strengthening opportunities in the education system for children, youth, and emerging adults. Also expanding peer support training and peer-to-peer support opportunities, as well as Canada-wide competencies for professionals. And these were 2 that were really much advocated for the young people as well. And lastly, in our last subsection, which focuses on backbone support to generate momentum and sustain change, there we focus on providing funding incentives and increased funding, also dedicating time and funds to improve evaluation, data collection, research and knowledge exchange, and emerging adult mental health. And lastly, having champions of emerging adult mental health so that we can actually mobilize the work for change. What was really great about modifying our approach was that our recommendations actually did change quite significantly after the conference, and they really spoke to what the conference delegates and the emerging adults and the jury members were hearing and really wanted to advocate for. So we really do feel that by taking this time, we have a much more fulsome report. So in terms of our next steps, we have one part of work that we're still doing, which is very, very important in this consensus statement, and that's our engagement with First Nations, Inuit, and Métis youth. what we learned during this consensus conference was, although we had representation of Indigenous populations at the conference, and we did have a First Nations Inuit and Métis jury member, our jury members and our delegates felt there was not enough substantive presence and dialogue at the conference to appropriately develop a recommendation that addresses the needs of First Nations, Inuit, and Métis stakeholders. And so what we've done is we've worked very closely with the 3 jury members who were First Nations, Inuit, and Métis at the conference, and have spent the last several months, specifically in the summer and even now, engaging with the Assembly of First Nations, with Métis Nation, and with Inuit Tapariti, for that we respectfully engage with young people and that their voices are really amplified in that document. We also made a commitment that we would not release this statement unless we had that engagement or had their voice amplified in the document, which is why we have not released the consensus statement. We've also worked closely with a research team from the McMaster Children's Hospital to engage with our conference delegates to look at how knowledge exchange can offer, how this consensus conference can offer opportunities to align health policy and service delivery. And lastly, what we're hoping to do once we release the consensus statement is to have an open call for a Canadian advisory group. And we're hoping that this group will help us to, or at least advise us on how to best advance the recommendations across sectors and jurisdictions in the consensus statement. So some of the key quick lessons learned that that emerged from the work that we've done is that prior engagement with youth is very important. It's also very important to have a mix of policymakers, resources, clinicians, and service users when you're having these discussions, and also to include individuals from across sectors. It's important to have advanced work with the jury. We did develop a framework and a policy statement for the jury to review, but they also did indicate, although we had more meetings, having an in-person meeting would have been really helpful for them. Also, early engagement of First Nations, Inuit, Métis national organizations is key. We had initially engaged with our Aboriginal partners, but what we've learned is that we probably didn't have the strongest relationships when we did their engagement. So we had to spend quite a bit of time developing relationships, and it's not just about early engagement. What we've learned is about respectful engagement, and that's something that as an organization we're working on, and it's definitely been a learning journey for many of us. And lastly, it's very important to have good support for youth during the conference. We had a lot of youth who are very vulnerable, and we're speaking to a lot of their experiences, and often that provides a lot of triggers for young people. And although we did have clinical support, it's important to have enough to ensure that all young people feel supported and have good self-care even after the conference. So next slide. That wraps up just a summary of some of the work that we did with the focus on the consensus statement and conference. And I know I asked you before, what are some strong practices in your jurisdictions and how can we learn from your existing networks? I also have a few other questions to throw out at you, and if you don't want to answer them or if you have your own questions, that's also fine. So how do the consensus statement recommendations align with your work, or what are some ways to advance these recommendations? So that's something to think about moving forward.
Great. Thank you so much, Despina. And Despina's contact information is on the slide on the screen if you'd like to contact Despina directly. So I have a few questions that have come through so far through the chat box feature, but please, as we address the questions that have been sent so far, please feel free to add in any additional questions that have come up through your engagement in the last few presentations. So the first question is for you, Michael, and it's really a two-part question. We've had a couple around funding. So the first part of the question is, are you able to give an idea of the amount of funding and investment that has been made by the government to enact these improvements? And the second part of that question is, have there been cost-saving projections based on the model as well? Because that's something that you did speak to around in a few of your slides. So if you could start with the first part and then go into the second.
Sure, thanks, Nicholas. So yeah, in terms of the first part, government yet hasn't decided on how much investment they will make. Currently, the Child, Youth and Family Service receives about $700 million New Zealand a year, and the projection is that by 2019 that could go up to $1.3 billion, which is a pretty big additional investment. But actually, the government's yet to make a decision just how far they'll go. But the signals there, they may go as high as that. In terms of the cost savings, there is some work that has been done around cost savings. They've looked at the Washington State Institute of Public Policy cost-benefit work that's been done and have put a dollar rating on the potential net benefit return on investment if those interventions when they were applied in Washington State. And I guess they're making the presumption that the same thing could happen here too. I haven't seen a more detailed New Zealand focused cost-benefit analysis or projection. That's not to say the government hasn't done one, just I haven't seen it. There will be some new costs by increasing the age of care to 18. They are projecting that will cost $6 million in year one, rising to $39 million in 2019. That's a result of approximately 500 young people staying in care beyond their 17th birthday. And they've also, they have put in things such as that they know that $1 spent on foster care after the age of 18 will return $2 worth of benefits for the young person as a result of future savings. So they see even that cost, increased care cost, actually having a net benefit in the long term.
Great, thank you so much, Michael. The next question is for Despina. Despina, thank you for describing the consensus process and the lessons learned. A question that came through was, how long did it take to plan the consensus process?
The consensus conference itself, I would say probably from its original inception to its delivery. For the conference itself, it took about, I would say, 8 months. And then maybe even a little bit longer, but then add to that the deliberations that we did with the jury and the EAs to actually finalize a consensus statement. It's probably almost a year of planning and work.
Thank you. The next question is for Michael. The question that's come through is, have the Signs of Safety program been successful in New Zealand with the supporting data that they have?
Sorry, Nicholas, can you repeat the question?
Sure. Have the Signs of Safety program, has it been successful in New Zealand?
As far as I know, we haven't implemented Signs of Safety. It's not a program I've heard of before. We have implemented other evidence-based models in New Zealand, and my agency has been one of the agencies that's done that. So we've done studies on functional family therapy, for example, and have demonstrated that the effect size of change is equivalent to studies overseas. But I think there's going to be a lot more, well, certainly I'd hope, a lot more implementations that take place in the next 4 years, and research that is connected to those to establish whether they are effective in the New Zealand environment. I know there's a lot of, certainly there's a fair amount of concern that introducing models from overseas may not be effective for our indigenous population in particular. So I think very careful research has to be done in order to allay those fears, but also to genuinely test whether the outcomes are equivalent.
Thank you, Michael. The next question is for Despina. The recommendations that you highlighted in the consensus document that will be released soon, will you be tracking progress on the recommendations after they're released and moving forward?
So will we be tracking the recommendations?
The progress on the recommendations.
Well, that's what we're hoping to do with our advisory group, is to identify or for them to help to advise us on how we could not necessarily just track the recommendations, but where there are opportunities for implementation and uptake. Obviously on our website, we'll be tracking them for a variety of different reasons, but we'll probably work with our advisory group to see what that implementation and KE strategy will look like.
Thank you. A similar question for Michael that just came in is, how will the recommendations be sustainable to keep children with their own families?
I think that's largely going to come through in Year 4 when there are prevention interventions put in place. So they'll be targeting that much younger age group, the 0 to 5-year-old age range, with interventions like Triple P and Nurse Family Partnership. Now, the assumption there is that if we intervene early enough with these troubled families, that family preservation is a much more likely outcome. It becomes much more challenging, of course, when we're intervening with adolescents and families, where the behaviours are more difficult then to shift. So that's the expectation. Whether there'll be an increase or decrease in the number of children who go into care will remain to be seen. But I think there's a bit of a sense in what I've been reading from the report that there is concern about children sometimes being placed back with kin carers or placed back in their own family without sufficient support, or because there's a higher risk of re-victimisation in that family environment. So we may see a shift to more out-of-home placement happening where those risks are assessed as still being present despite the availability of other interventions.
Great, thank you, Michael. Another question for you, Michael, was a question just came in about the involvement of youth in developing the plan, and if you may have highlighted it, but just if you could restate that portion if youth were involved in the development of the strategy.
Yes, your children and youth were involved in it, and it's been a big push actually that the expert advisory panel had. So they consulted, as I understand it, a significant number of young people who'd had a care experience. Through their report, if you have a chance to look at it, there's a number of references to what children have actually said about their experience. And with the new youth advocacy service, that will also have a youth council that's connected to it, so that the advocacy group, closely connected to that youth voice.
Thank you, Michael. Dina, you had mentioned in your presentation the different definitions of youth and emerging adults. Have you found throughout Canada that there isn't consensus on the age of youth and emerging adults? Is that something that has been consistent finding?
That's actually a very good question, because at the consensus conference we spent quite a bit of time trying to figure that out. So what we learned from the literature, 16 to 25 is often the age cohort that is used, and again as young as 14 or up to 30. So we're hoping to, with these recommendations, that this may be a conversation that could support to maybe have some more consensus around that, not just within the mental health field, but across sectors as well.
And Michael, maybe the same question. In your presentation, you had mentioned that you had changed the definition of youth going up from 17 to 18. What was the process to do that?
We've changed the age of being able to remain in funded care, to stay in custody with the agency. So the mechanism there is they're changing legislation. So it's going through the passage of select committee at the moment. I think the expectation is that it will coincide with the start of the new agency in March next year. That at that point, young people who are aged 18 will also be able to access, will be able to remain in care if they need it. And that's just simply a legislation change.
Okay. Thank you so much.
And sorry, I just wanted to add something to what I mentioned earlier. Another point, when you mentioned about that age cohort, one large discussion that took place at the conference is to really try to recognize emerging adulthood as a developmental stage of life instead of categorizing and limiting services to age. So we do have within these recommendations a paragraph where there's some call to action. So we do elaborate a little bit more on that within that specific recommendation.
Thank you, Steve. A question that I'll add to my response too, that there's also a commitment that for some young people who they can remain in care at their choice up to the age of 21, that funding will become available for that. That will be an attempt to mirror what happens in many New Zealand families where young people do remain in the home and attend university because the cost of transitioning to adulthood and living independently is so enormous that it prevents many young people from taking up employment and education opportunities. So that's, I think, a really positive change that the government's looking to invest in.
Great, thank you. And the last question, it wasn't addressed specifically to either, but applies to both. So I'll let Despina answer first and Michael second. What recommendations do you have regarding early intervention in schools, and are there specific programs and community partnerships that are built from that?
I know that we do have a recommendation that really focuses on investing in education systems for children, youth, and emerging adults. So that one really focuses on fostering resilience and mental well-being as they progress through the spectrum within their education learning. So within that, we do speak to early intervention and prevention as well, too.
Michael?
And for us, yes, for us in education space, there have been some recommendations from the panel. One of the interventions I've recommended is Check-in-Connect. It's a program in schools where there's a regular connection with young people throughout the week around their grades and their success in the school environment, which has had some success, I think, in randomised trials in the US. They've also recommended a program called Career Academy, which I don't know anything about, but it's also been a US-based intervention which has shown some success. And one other called Becoming a Man, which is a high school behavioural program, which offers non-academic interventions with disadvantaged at-risk males, which has shown success in a US randomised trial. So those are the three interventions I recommend.
Great, thank you, Michael. Due to time, there are a few questions that the presenters were not able to answer, but on the last slide, you'll find contact information, which if you send your outstanding questions, we will be sure to answer them. So just before getting to that, I just want to thank both Despina and Michael again for taking the time to share your work with us. And I wanted to highlight a quick note about the upcoming IMHL Leadership Exchange. The next IMHL Leadership Exchange will take place in February 27th to March 3rd in Sydney, New South Wales, Australia. The philosophy behind the exchange is that once key leaders are linked together, they have the opportunity to begin collaborating and building international partnerships to build relationships and networks that are mutually helpful to leaders, organizations, and countries. There will be a large section of matches or workshops on a variety of topics across the mental health spectrum. To learn how to become part of the IMHL network or attend the conference, please check the IMHL website for more information at www.imhl.com. Also, for those interested, there are specific child and youth-related matches. There's one specific to innovative clinical approaches to child and youth mental health issues, one specifically on transition-aged youth, another on leaders in child and youth mental health, systems, issues, and solutions, and finally, one focused on prenatal and infant mental health. Again, and thank you for attending and joining today. And I do ask that you please take a minute to fill out the 4-question survey at the end to help us evaluate. And as I said on the last slide, you'll see information for Keely Brack. And if you send any outstanding questions, we'll make sure that the presenters answer them, and we will post them along with the slides and the recorded webinar. So thank you for joining, and have a good evening, morning, or afternoon.